The central nervous system, part 1. If you'll notice, this is going to be a lecture divided into 2 parts simply because of the sheer amount of volume that comprises pathology associated with the central nervous system. So I feel that in order to encompass this, it's best to split it into 2 sections, and right now we'll be covering part 1. So just a simplistic overview, we have the cerebellum, which is in the posterior portion. Slightly below the occipital lobe, we have the cerebrum. And then we have the brain stem, which is comprised of the midbrain, pons, and medulla oblongata. Medulla oblongata sits directly below the pons, which this is the pons, and this is the midbrain. And so that is pretty much all the specific anatomy that we'll cover, because we're going to be focusing more along the lines of pathology. Additionally, the structures that we have, just so that you can visualize what we're looking at, this is going to be the frontal horns of the lateral ventricle. This is going to be the third ventricle. This is the basal cistern. Okay, this is the falx cerebri here. Also, you're going to have scalp here, and then we have the actual cranium there. The reason that we go over the frontal horns of the lateral ventricle is because it will become very apparent when you have something like a brain tumor where it causes a shift in the brain, or it causes compression of these ventricles. And so it becomes essential that we know what a normal ventricle looks like. Also, you'll hear this referred to as, I've heard several physicians refer to this as the face. You have the eyes here, you have the nose, and you have a smiling mouth here. It has been said if this mouth is frowning, then you have probably some serious problems. But as long as it's smiling, that means things are looking okay in the brain. Additionally, the brain is subdivided into several sections. We have the longitudinal fissure, which goes up and down. We have the central sulcus, which goes across, and that's all we're really going to worry about from this image. Additionally, this is something that we kind of need to know, and I'd like you to put a star by this, because this will kind of come in handy when you're looking at specific pathology and how the patient is being affected. We see the left brain controls logic, verbal, detail, science, math, names, forms, strategies, involved in order and thinking and writing. And so that is all left brain. The right brain functions as a picture, stories, looking at things from the big picture, observation, shapes, music, patterns, beauty, imagination, and possibilities. So it can be said that the right brain is more of the imagination portion and the left brain is more of the logical portion. Additionally, we have layers until we get into the brain. We have the scalp, which is referred to here as the skin. Just below that we have the periosteum, which is part of the bony matrix, and then below that we have bone. Then we have the dura mater, the arachnoid, and the pia mater. So keep these 3 in mind: the dura, arachnoid, and the pia mater. Know that the dura is the most superficial and the pia is the most inferior. And so another thing to keep in mind is that if you have right-sided damage, you're going to have left-sided effects. And vice versa, if you have left-sided damage, you're going to be affected on the right side. So that brings us to initially just some types of infections, such as encephalitis, meningitis, and an abscess. Encephalitis is a viral inflammation of the brain and the meninges, and it presents itself as a diffuse or focal neurophysiological dysfunction. Patients with poor prognosis include patients less than 1 year of age, greater than 55 years of age, immunocompromised, and or having pre-existing neurological conditions. If we'll notice, the immunocompromised typically do fall into both of these categories. People greater than 55 are at risk, and patients who are less than 1 who have not built up an immune system to the full extent are in this category. So what causes encephalitis? It's hypothesized that the herpes simplex virus can cause this. Measles, mumps, and the rubella virus. All of these things have a tendency to predispose someone to encephalitis. The symptoms associated with encephalitis are behavioral and personality changes, usually sudden onset, a decreased level of consciousness, kind of wanting to be lethargic, a neck pain and or stiffness, photophobia, lethargy, seizures, and confusion. All of these things can be a symptom of encephalitis. So the method for diagnosing encephalitis initially begins with a lab test such as CBC and comprehensive metabolic panel. Comprehensive metabolic panel will kind of demonstrate whether certain organism systems are functioning correctly, and the CBC will indicate whether there is inflammation or a possible inflammation in the body. Probably the most prominent and accurate method for diagnosis is the lumbar puncture and analysis of the spinal fluid, but CT, MRI, and biopsy can also be utilized. Looking for encephalitis in terms of CT, we found that on initial scans, abnormalities may be demonstrated as a low-density lesion. That's what we're going to look for, a low-density lesion. It's going to appear black. Mass effects may be seen, which are the results of lesion tumors in the brain. And when we talk about mass effects, this is what we're talking about: midline shifts, and which are a result of mass or masses compressing the ventricles. Many times CT will better demonstrate this 3 to 5 days after initial scan. So usually a follow-up scan after the initial one will better demonstrate encephalitis. Non-contrast scans will demonstrate low-density areas in the temporal and frontal lobes, and contrasted scans will display ring enhancement. And we'll see what that looks like in just a few seconds. Here we have just a generalized low contrast area in the brain that seems to be abnormal, as well as this low contrast area. Furthermore, this is magnified here. We have this in the temporal lobe. So another type of infection is meningitis. Meningitis is a clinical syndrome characterized by the inflammation of the piedmontal and the arachnoid, or also the spinal cord. Around 80,000 cases of meningitis occur annually. Around 8,000 cases of meningitis occur annually, and of those 8,000, 2,000 will die from meningitis. So we'll see that it's quite deadly for those who actually do get it. It can be caused by both bacterial agents and viral agents, so you can have bacterial meningitis and viral meningitis. Bacterial meningitis is the most common form, with the bacteria releasing toxins that destroy the meningeal cells and triggers an immunological response. And so that's how the process actually occurs. The bacteria kills off meningeal cells, and the body initiates an immunological response, which may or may not be effective. So what causes meningitis? In short, an invasion of the bloodstream by bacteria, virus, and or fungus with seeding of the central nervous system. So somehow it crosses over into the central nervous system. A retrograde neuronal pathway, so it works its way up the spinal cord, and then an extension of such things such as otis media, mastoiditis, and sinusitis. So the scary thing about meningitis is the third bullet point. You can have ear infection, inflammation of the mastoid air cells, and or persistent sinus infection, and all ultimately wind up with meningitis. Not everyone who undergoes each of these things are going to have meningitis, but for those 8,000 that actually do, the prognosis is not the greatest. So symptoms of meningitis are nausea, vomiting, photalgia, which is discomfort when the patient looks into bright lights, also called photophobia. So the patient just experiences a glaring pain simply because of bright lights. They have sleepiness, confusion, irritability, delirium, and even coma. Can all be symptoms of meningitis. So the workup for diagnosis for meningitis initially is the lab test, such as CBC and comprehensive metabolic panel. Once again, we find that lumbar puncture is the way to go, simply because it allows cerebrospinal fluid to be analyzed and then returned back after the analysis. Additionally, CT and MRI can be utilized. Okay, so that brings us to what meningitis actually looks like on CT. As we can see, meningitis can demonstrate by the demonstration of edema and hemorrhage in the meninges. However, many times initial CTs are normal. So many times if you're looking for meningitis and you do a routine CT for it, chances are you might not actually see anything. It would be a rarity to see a hemorrhage or edema initially. However, as time progresses, we see possible compression of the lateral and third ventricles, which we've already reviewed what they look like. And so what we mean by compression is that you see the horns of the lateral ventricle coming in something like this. And compression might mean that instead of looking nice and wide, you might see the ventricle looks something like this. And so there's a great asymmetry. That's what you're looking for, asymmetry among the lateral ventricles. You can also see hydrocephalus caused by thickening of the arachnoid. But the most prominent thing that you're going to see is the compression of the lateral and third ventricles, and possibly a hemorrhage later on. So let's visit this link. Okay, so if you'll notice after we click on the link, it loads up this website. And the reason I integrated this website into our study on meningitis, and you'll see this come up over and over again as we look into abnormalities of the head, is that I feel that it is best to look at things in terms of scanning if we can, or if we have the ability at all, and especially amongst the head. And so what we're going to do is we're going to click on the non-contrast portion, which is going to load up a non-contrast CT head. And so initially, as we can see, we have a little bit of thickening of the maxillary sinus, probably consistent with sinusitis. And as we scroll through, just initially, doesn't look greatly impressive. But what we're looking for is this area here, which is noticeably some edema. It's slightly hypodense versus the surrounding tissue. And notice we might have slight compression of the left lateral ventricle. And it almost looks like some edema here running along the outer border of the brain, because notice we have a lack of symmetry here. We see it even more in the frontal region. And notice this is CT on admission. If we scroll down just even further, we see a CT 1 day later. And this scan, as we're going through the patient, notice we have this area here. And that's pretty much it for meningitis on this 1 week, 1 day later. So while the effects of meningitis sometimes aren't easily seen on the brain, we do see a causation for meningitis. Notice we have a sinus infection here, which we've already kind of pointed out, but we're looking at it in bone windows. And so if we begin initially again, see we're coming through and we're getting the mastoid air cells bilaterally. As we keep scanning through, we have the TMJ on bilaterally as well, and we see the EAM coming in. And then as we're scrolling in, we see this strange area on the right. It looks a little strange because we see almost the EAM kind of compressed. Let's look at the left side and see what it's supposed to look like. See how nice and open it is? If we go back, we see that it's not open here. And also the mastoid air cells, as we can see, possibly mastoiditis as well. And so because of this, this person has got meningitis. So let's go back to our slideshow now. So an abscess. An abscess is a collection of immune cells or pus and other material in the brain. It commonly occurs when fungi or bacteria infect part of the brain. And it may cause swelling, irritation, and other symptoms that can cause abnormalities with the brain. And the big thing is that it causes an immunological response, which results in isolation of the infection. So the body is attempting to do something good by isolating the inflammation. However, this can sometimes increase swelling, which can include blood vessels and increase intracranial pressure. So because the body attempts to isolate, the end result can be swelling simply because of this isolation. And as we know, the cranium, calvarium, whatever you want to call it, has a finite amount of space inside. Which means that basically the skull, after you reach adulthood, cannot expand any farther than what it already has. And so when your brain begins to swell, there's nowhere for it to expand. And so it increases intracranial pressure, which can then cause very drastic changes in the brain mass itself. So what can cause an abscess? You would think that they are not very common, kind of one of those things that you might or might never see in the course of your career. So what causes it is possibly a weakened immune system. It allows you to get infections more rapidly. Chronic disease such as cancer, which kind of goes back to bullet point number 1. If you've got cancer, chances are you've probably got a slightly weakened immune system due to treatments that you're receiving. Drugs that suppress the immune system. and right to left heart shunts, strangely enough. But typically the first three are what we actually see might be the causation of it. So the symptoms of an abscess are confusion, drowsiness, irritability, decreased movement, decreased sensation, fever, headache, seizures, loss of coordination, stiff neck, and vomiting. And so all of these things can kind of fall under the banner of an abscess and what might be the result of it. And so as you'll see, it all kind of stems from abnormalities in the brain, decreased movement, decreased sensation, headache, seizures, things like this are all just kind of symptoms that point to the brain. So the workup for diagnosis is quite simple. Lab tests such as CBC and comprehensive metabolic panel. We should also say CRP, C-reactive protein, to see if there's inflammation in the body. Additionally, you can do a spinal tap to see whether there's actually inflammation working its way up in the spinal cord, being as this will be really the only way for it to actually happen unless you had septicemia, which is sepsis, traveling through the bloodstream and disruption of the blood-brain barrier, which could cause the pathogens to transfer over into the actual brain matter. However, that would be highly unlikely. So chances are it's coming up through the spinal canal. Also, CT, MRI, and EEGs all play a role in the demonstration of this. So what it looks like on CT is a central low density. So it's going to be hypodense. Additionally, could represent an iso or hyperdense ring. So it could be a small ring which is hypodense inside, but just a ring that looks hyperdense or same density as everything else. Peripheral low density. Ring enhancement. This kind of goes back to the iso or hyperdense ring. Ventriculitis may be present, in which case hydrocephalus will commonly also be seen as well. As we know, hydrocephalus is accumulation of cerebrospinal fluid in the brain, which widens out the ventricles. So typically you might see this as well. So here we have an abscess, and it's this area here. Notice how it's hypodense. But also notice if I erase what I've drawn around it, notice that there is a ring here that is hyperdense. So we do see that we have a hyperdense ring. Here's a better example of an abscess. As we can see, we have associated edema here due to this mass swelling. So this is edema. We have the hypodense area on the inside, but notice we have a ring going around the area. So we have a hyperdense ring. So technically, this should be very easy to distinguish for your examinations, basically because you're going to be looking for a hyperdense ring. The two images that we saw so far have demonstrated this. Here's another hyperdense ring as well as a hypodense area. And so what we presume is that this is basically the body trying to isolate itself, which causes all this hyperdense ring and enhancement and things like that. And so this is just a huge pocket of inflammation inside the brain. And so it would be interesting to see what these patients actually look like and when this inflammation is actually cleared up, or if inflammation ever became cleared. because once you damage portions of the brain, chances are it will not recover, depending on your age. And so, would this area actually recover back? That would be anybody's guess. So that brings us to one of the common, or probably the most common thing that you'll ever encounter in terms of CT. The patients that are having a stroke. And so let's just throw this out there and get it off the table right now, that not everyone who comes in having stroke-like symptoms is having a stroke, but not all the people that we don't see a stroke on in terms of CT aren't having a stroke. And I realize that may not make any sense, but hopefully it will by the time that we're done. There are so many things that can cause stroke-like symptoms that are not necessarily strokes. So just because someone is having symptoms of a stroke doesn't necessarily mean that they are having a stroke. So initially we see that a stroke can be referred to as a cerebrovascular accident, or a CVA, and the term stroke denotes a sudden and dramatic development of focal neurological deficit. So basically, a stroke represents an abnormality with the brain that occurs suddenly and without explanation. It can vary from hemiplegia, coma, and trivial neurological incidents. So basically, you can have one side of the body that is weaker or not able to move. You can be in a coma. You can just have trivial neurological incidents such as inability to talk. I've had several patients who actually have been having a stroke. You be talking to them and they understand you, but they cannot turn what you're saying into words so that they can speak something back to you. So maybe they're not able to give you their date of birth. Maybe they're not able to give you what today's date is, or what the nearest holiday is. Things like this are all symptomatic of possible strokes. And we see that strokes primarily involve the circulation of the internal carotid arteries. So typically we're looking for the internal carotid arteries, and there being an abnormality somewhere in those. So there's two main types of strokes. Many times we get it totally wrong and we think that there is just one type of stroke. Actually, I've had ER physicians look at CTs of the patient and say, oh, well, they don't have a bleed, and so there's nothing wrong. But we typically just focus on patients having bleeds, and we fail to see that there's two types of strokes. Number one, there's ischemic stroke, which is the kind that we kind of forget about. And it's caused by an interruption of the blood supply to the brain. So to break this down very simple to you, an ischemic stroke is kind of like what you have with a heart attack. If we think back to what a heart attack is, it's an occlusion of a blood vessel that supplies the heart with blood. And so which one of your coronary arteries is it? It can be either one, but it stops supplying the heart with blood. And so there's a clot in there that has lodged, and there's nothing able to get past it. And that's kind of what ischemic stroke is, that there is a clot, there's a clotting effect which causes interruption or inability to supply parts of the brain with blood. And because of this, just as the heart muscle will die if deprived of blood, the brain will die, or parts of the brain will die if you're not able to supply it with blood as well. Hemorrhagic stroke is something that everyone tries to focus on, and it's caused by a rupture of blood vessels or an abnormal vascular structure. However, your hemorrhagic strokes are going to be quite rare in comparison to the ischemic strokes, because we see that most strokes are of the ischemic type, and they're around 90%. So 90% of your patients are going to have the ischemic stroke versus the hemorrhagic stroke. And this becomes very important to really distinguish, because in the ischemic stroke, there are clot busters that can be given to hopefully reverse what has been done to the brain. However, these have to be applied within a very short amount of time. Usually it's within a 3-hour window, which means that the patient has to get into the hospital, get started with diagnosis, go to the radiology department, get a report back that says yes or no to the ischemic stroke. And even if the report doesn't kind of say ischemic stroke, is there enough of the symptoms there on the stroke scale for the ER physician to treat the patient with a stroke and bust the clot. And so all of this has to be done within a 3-hour window, and sometimes it becomes quite dicey to actually carry everything out. So the etiology of the strokes are very different, and we'll see that. An ischemic stroke results from a thrombus or a thrombosis, embolism, or can result from systemic hyperperfusion, not hyperperfusion, which means loss of blood, and venous thrombosis. And so basically, ischemic stroke results from a clot. However, it can result from being volumetric loss of the blood to the point to where there's not enough blood to actually pump to the brain. And so that can mirror the same effect. But the thing you have to know about ischemic stroke is that it's due to lack of blood supply. So that's what we're going to focus on ischemic stroke. If you want to boil it down to its closest or its most simplistic etiology, and it's quite simple. It's just a lack of blood supply. A hemorrhagic stroke does not have this lack of blood supply, but it is basically a vessel that has ruptured. And so we're going to put that there, rupture vessel. And this can be due to AVMs, which we'll discuss later, aneurysms, bleeding disorders, and or trauma. You'll see that aneurysms are the high majority of cases where you're going to see things just kind of go haywire inside the brain. Trauma can also cause a stroke or hemorrhagic stroke. And so these are your two most common aneurysms and traumas. So the symptoms of a stroke are sudden paralysis of a leg, arm, or one side of the face. Typically everything will be isolated on one side of the body, and typically it may only affect a leg or an arm, but many times patients report that it affects the entire side of the body to where they're just not able to move that side of the body really well. It may not be complete paralysis, but it may be just the inability to move it, as well as the opposite side, such as a feeling of heaviness on the arms or legs. And so you try and move it, and you can move somewhat, but you can't move it to the full extent that the other side is. Another thing is facial drooping, things like that. Sudden trouble speaking or understanding speech. Usually, I've had several patients not have the inability to understand speech, but have trouble speaking. And they comprehend what you're saying, and it's registering in their mind, but they can't actually formulate the words to speak back to you. Sudden vision problems such as blurred or double vision. Sudden loss of coordination or problems with balance. We see that sudden loss of coordination and balance problems can also be indicative of tumors inside the brain as well. A severe sudden headache without apparent cause. You see this a lot with the hemorrhagic strokes, where the patient is just complaining of a severe headache, sudden onset. It is almost the most excruciating thing that you can have. Also sudden numbness, weakness, or dizziness. And so that kind of goes back to the first bullet point, where there's just really no explanation, but all of a sudden you get weak and you're not able to move. So in terms of stroke, we see that CT has a very low sensitivity for ischemic stroke, around 16%. This is possibly the worst thing about CT, is that for ischemic stroke, it's only around 19% for the initial phase. And so what that means for us is that basically there is a strong majority of cases where the patient may be having ischemic stroke and we're not able to detect it, just based on the initial scan. That's why many times you'll hear 24-hour, 48-hour CT scan reordered for the patient. to see if there is actually something there. Bad news is that if you're in a facility that does not have MR and you have a patient that comes in for suspected ischemic stroke, and they're a high probability patient for an ischemic stroke, only about 16% of the time are you going to be able to find that ischemic stroke. And so what that means for the patient is that they're going to get outside of this 3-hour window where treatment needs to begin to save that part of the brain. And so chances are that time window is going to pass and the damage is going to be done to an irreversible extent. However, if you compare detecting ischemic stroke in CT to MRI, see that MRI has around an 85% sensitivity level for both ischemic and hemorrhagic stroke. And so MRI can really detect ischemic stroke where CT can't. And so if you're looking for an ischemic stroke, chances are MR is going to give you a better outcome for that. CT, though, has a relatively high sensitivity for hemorrhagic stroke, around 89%, which is 4% greater than MR. However, the big thing about CT is that it's more readily available than MRI. However, in the cases of looking for ischemic stroke, CT just kind of falls through the cracks here. So what you should see in terms of manifestation of strokes, in both types, scans should be performed without contrast. Notice this is in bold print. Strokes can cause disruption of the blood-brain barrier, allowing contrast media to cross and cause edema and result in a slower recovery time for patients. So if there is a suspected stroke that is going on in the patient, then definitely do not inject the patient with contrast. I've had probably 3 incidences in my career where I have been scanning a patient and the exam has been ordered with and without contrast, and I see something that looks like a hemorrhage and I have to send it out. One time it was a mass that was causing a hemorrhagic effect in the brain, and the radiologist said that I could go ahead and inject the contrast. The other 2 times they were hemorrhagic strokes, and the doctor or the radiologist advised just to end the study there and to be done with that because there was no need for contrast. And you'll hear a lot of radiologists kind of be a little different on what strokes and contrast will do for each other. Most agree though that because there's this disruption of the blood-brain barrier, you're allowing for things to cross over into the brain. And if you're allowing things to cross over into the brain, it's not like the contrast that we're going to inject is going to remain in the body for years and years and years and years and cause all kinds of problems. But for the initial phase, it can cause problems because you're allowing more fluid than what would necessarily be going to the brain to go there. And because of this, you might actually increase intracranial pressure, and this can cause a vast array of problems with the patient, or even further enhance what's going on. And so we ultimately don't want to impede the progress of the patient. So this can result in a slower recovery for the patient, and we don't want that. So if a stroke is suspected, do not perform with contrast until you get an opinion by the radiologist. Ischemic stroke, initial appearance within 8 to 24 hours. It appears as a triangle or wedge-shaped area of hypodensity on CT. The trick here is noticing that it's hypodense. It's going to appear very, very black in comparison with the other brain material. Hemorrhagic stroke, on the other hand, appears as a homogeneously dense, well-defined lesion with a round or oval configuration. And so hemorrhagic stroke is going to appear white. Ischemic stroke is going to appear black. And so let's write that there to kind of keep them straight. Also, you look for ventricular compression and or midline shift. We saw that before. You're going to look for lateral ventricle compression And also, notice how the brain is supposed to have symmetry. Midline shift is going to disrupt that symmetry and push it over to one side. You may not see that with a stroke, but you may see that more often with a mass. It typically occurs in the basal ganglia, white matter, thalamus, cerebral hemispheres, and pons. And we're not going to worry so much about where these occur, because once you see it and once you really know what it looks like, it's going to be very hard to forget what it looks like. It really won't matter. If we say that it typically occurs in these areas, we can kind of get an idea of just looking at these areas and seeing if there's abnormalities and not looking at the big picture. So I like looking at the full scan versus just these small areas. So here we have an ischemic stroke. This would probably be several days out, probably 2 days. Notice as we're coming in, we're still seeing bony anatomy coming in, and so it's kind of obscuring everything. But we see this area here, and so this is the hypodense area, and this is an ischemic stroke. But also notice that there's this area here, which can be defined as edema coming in as a result of this hemorrhagic stroke. Notice we have the obliteration of the right lateral ventricle, which should be existing here. Notice we don't really see anything. We have compression fully of it. We have a large ischemic stroke comprising probably 1/3 of the parietal lobe. And notice we have possibly edema or another ischemic stroke here on the opposite side. So basically, because we're seeing this in the right side, a patient is probably having left-sided weakness, left-sided abnormalities. However, because we have this area on the left side, there could be bilateral weakness as well. Notice how hypodense it is, how black it is in comparison to the other portions of the brain. That's typically what you're looking for, is just this hypodense area. We don't get so caught up in a triangle shaped area or things like that. But once you see an ischemic stroke, you usually will know what to look for from that point on. Here's another ischemic stroke with a midline shift. Notice the midline is right here. This should be the symmetry point of the brain. So whatever you see on the left side should mirror on the right side and vice versa. However, we see that this huge area of ischemia or ischemic stroke, and notice it's hypodense, it goes all the way to the cranium, and because of this area we have midline shift. Notice there's lack of symmetry. We have compression of the lateral ventricle on the right side, and we have a shift over to where this should be the center point, but between the ventricles, and notice it's not in the line where the center should be. So it's a very obvious midline shift. Let me erase everything so you can look at it again. Very obvious. You just see everything of the brain just kind of pushed over. Very unfortunate. Here we have an ischemic stroke again. On this image, they've kind of colored the area. Again, that's not ischemic stroke with blue, and they've kind of isolated the ischemic stroke area and kind of demonstrated to you what an ischemic stroke is. As you can see, an ischemic stroke is when you have plaque in the arteries and then the clot comes through and won't allow anything to pass through it. So you cause pretty much death of the tissue area that's not being supplied with blood. This area looks more of a wedge shape than what we saw, and as we can see, this is one of the least traumatic areas that we saw, because notice there's no midline shift. There might be slight compression of the right lateral ventricle to some degree, but not much, and it doesn't comprise a large portion of the parietal lobe. On the other hand, this is hemorrhagic stroke. Notice that ischemic appears black, well, hemorrhagic appears white. And It's not going to look as white as bone, but blood does give the appearance of white when it's. And so this is a hemorrhagic stroke. I notice we have calcifications in the choroid plexus here and calcifications in the pineal gland. Those are quite obvious, and you should know what those look like. Additionally, notice that we have some edema going on probably here, causing compression of the left lateral ventricle. But we do have no associated midline shift, or maybe a slight midline shift, but not very much. But this is the hemorrhagic stroke. And notice there's been measurements taken in the planes here to kind of distinguish how great it is. Here is a very, very difficult hemorrhagic stroke. To kind of pinpoint where the abnormality is, we have blood filling lateral ventricles. So as we can see, there's blood inside of it. And notice we can really distinguish what blood looks like, because here's what a calcification looks like. It's bright white. Calcifications are going to be the same density usually as bone. So it's very hard to distinguish bone from calcifications. But it's very easy to distinguish bone from blood. Blood doesn't have the density level that bone does. So in A, we would say that this is probably an initial scan for a hemorrhagic stroke. Then we get to scan B. As we can see, we have probably surgical intervention here to remove a portion of the skull to allow expansion of the brain. And we do see that we have expansion of the brain out into this area. We do have air here. And notice we have a severe midline shift. Here is the midline. The ventricles are pushed over. We see all this area being the hemorrhagic stroke. We don't really have an idea of what caused this. Based on the patient size and the brain type, it looks like this might be a very young patient, simply because of looking at it. Interestingly enough, the patient's skull diameter in this direction is close to skull diameter in this. So that could suggest abnormalities of the skull as well, or impeding growth. Here is a hemorrhagic stroke, and we can say pretty obvious with this that the patient has had trauma. I notice that there's separation here, there's fragmentation, and the brain has come out. Notice there's almost no separation between the scalp and the brain matter. There is a severe midline shift in this direction, and we have the hemorrhage here. We have associated what looks to be widening of the ventricles, which kind of allows us to see that this could potentially be an older patient. But notice once again that we're looking for a hyperdense area, which means that it's denser than the brain matter surrounding it. And so we definitely see that, but it's not quite as dense as the bone. So that is blood. So that brings us to a subarachnoid hemorrhage. The subarachnoid hemorrhage is a form of a hemorrhagic stroke, and it's basically a hemorrhage that occurs in the subarachnoid space. It can be caused by a rupture of a buried aneurysm, which we'll see. And it's most oftenly associated with excruciating headaches and unconsciousness. And so we see that CT and MRI are excellent for the subarachnoid hemorrhage and the workup for diagnosis. Usually lab results are non-conclusive and really can't be utilized. The best method for demonstrating this is simply looking at it in terms of CT or MR. So in terms of CT, we have high attenuation of blood in the subarachnoid spaces and increased density within the basilar cistern, cerebral fissures, and sulci. So we'll see what that looks like here. So here is a subarachnoid hemorrhage, and notice that we have pretty much a star pattern where it is going into all of the spaces of the brain. So here we see again subarachnoid hemorrhage. Notice the star pattern here. Here we see some portion of it. So that brings us to a brainstem glioma. It is the most common primary malignant brain tumor, and it consists of glial cells that still have the ability to multiply. The glial cells are the supporting connective tissue of the cerebro or the central nervous system. They have a peak incidence in middle adult life, and they're infrequent in people less than 30 years of age. There are several types of gliomas, such as glioblastoma, astrocytoma, medulloblastoma, epidemioma, oligodendrocytomas. But we see that the most common is the astrocytoma, which makes up around 75 or 70% of the gliomas. Symptoms include headache, nausea, vomiting, and seizures. And the workup can be MR or CT. So we see on non-contrast scans, gliomas are commonly seen as single, non-homogeneous masses. A glioblastoma will occur usually in the brainstem's cerebellum and spinal cord. The astrocytoma will occur in the cerebrum, cerebellum, thalamus, optic chiasm, and pons. The epidemiomas occur in the fourth and lateral ventricles. Medulloblastomas occur in the posterior portion of the vermis, and the oligodendrocytomas occur in the cerebrum. We're not going to worry about where everything occurs. We're just going to kind of put everything under the banner of a glioma. So if we go to this website, we'll see what one looks like. So here we have a CT, and as we're scanning through it, we see this area come in. And the interesting thing about this area is it's hypodense on the outside, but it looks like it picks up a little bit of a density on the inside. And so it looks like there is mass with associated edema effect. Notice we do have compression of the lateral ventricle with a slight shift over. And this kind of really paints the picture here. The compression, we have severe compression of the lateral left ventricle in comparison with the right ventricle. Venturing on, if we scroll down, we see we have an MR image, and here in the coronal plane, we can see that we have this mass effect, also with compression of the lateral ventricles. This image kind of demonstrates it as well. Looks like we have a center mass with associated possible edema surrounding it. And so that's going to be characteristic of gliomas. Well, this is a brainstem, not really a brainstem glioma. That shouldn't say brainstem, that should just be glioma. And notice we have this area of increased density on the inside, which looks similar to a mass with associated edema surrounding it in all of this area. And so we have this edema, but also notice that we have compression of the right lateral ventricle. No midline shift. We're keeping everything pretty much in the midline so far, but we do have compression of the right lateral ventricle. And so that's typically going to be your characteristic of glioma. Look for a mass seemingly on the inside of something like edema. So you're going to have hypodensity. If we draw it over here, we're going to have hypodense surrounding an area that is hyperdense than this. So that brings us to lipoma. And so we have already seen that with the musculoskeletal system and somewhat in the abdomen. And we can see that it can result in central nervous system lipomas as well. And so once again, the causation of lipomas are really unknown, especially in the central nervous system. The associated symptoms are none, because they do not increase in size and should not theoretically cause any abnormalities. And so the way that we distinguish what a lipoma is CT and MR. However, typically lipomas or finding lipomas are not usually the reason for doing a CT or MRI. Usually it's a chance finding or an incidental finding. We see that they are hypodense in appearance, meaning that they are black and they show no enhancement with injection of contrast. So they just pretty much look stationary in appearance. So here we have a lipoma, and notice that we have calcifications on the inside of it. It's hypodense, and it looks to be in the midline, and doesn't look like a mass at all. It just looks like an area of decreased brain attenuation. Here's another area. Notice the location. It's usually in the center, in the midline of the brain, and it just has these rough, indeterminate borders. But other than that, nothing really demonstrates to be very menacing at all. So here is lipoma as you're scanning through the patient. This is scan 1, 2, and 3. So this is image 1, 2, and 3. And so we see that we have a lipoma here going in the midline. As we continue on, have larger and larger appearance. But notice that there is nothing that looks to be on the inside of it, and there's calcifications on the outside. And so something that chances are probably won't cause any abnormalities inside the patient at all. So that brings us to a meningioma. Meningiomas refer to a set of tumors that arrive contiguously to the meninges, and they're thought to arise from the arachnoidal cap cells. These reside in the arachnoid layer covering the surface of the brain, and they're commonly found at the surface of the brain. Most are benign, though sometimes they can be malignant. And generally, they occur in mostly older women. For some reason, meningiomas target older women versus any other age group. Meningiomas are thought to arise from trauma and or viruses that have been postulated. Low-dose radiation could potentially be a causation effect of meningioma as well. However, one of the most prominent causations is abnormalities on chromosome 22. So that's something you want to keep in mind. Probably abnormalities on chromosome 22 is probably the most distinguishable causation of meningiomas. Meningiomas can be represented by changes in vision, such as seeing double or blurriness, headaches that worsen with time, hearing loss, memory loss, seizures, and weakness in the arms or legs can all be a symptom of a meningioma. So once again, CT and MRI play the most determining role in diagnosis, as really no lab results or things like that will be an excellent indication of something that's going on like a meningioma. So for CT, we see that non-contrast studies demonstrate a slightly hyperintense extraaxial mass, and so you're going to see possibly hyperdense. IV contrast demonstrates a marked enhancement, so it's going to enhance with IV contrast. And calcifications may be seen in 20 to 25% of all cases. And so you may see calcifications, but not likely. But IV contrast is going to be your really determinant step. So let's go to this link and see what a meningioma looks like. So here we see a scan of a patient who probably is just a routine scan for blurriness of vision, something like that. So as we're scanning through the patient, we start seeing something come in on the left occipital region, and we see that we have this what looks to be a mass that has contrast enhancement. As we continue on, really no other abnormalities in the side of the brain. Ventricles are quite small, so potentially this patient's not extremely old. Let's see if we have any age on the patient. Really nothing on it. So this is typically what you're going to look for in a meningioma. Hyperintense, with increasing in hyperdensity based on the injection of contrast. And so as we can see, we have the circle bullous holding the contrast in, and we see that this has contrast as well. So very characteristic of a meningioma. So here is our second slide that has images on it. So go ahead and click that link as well, and it'll bring up this. It's a Fowlkes meningioma. And so judging by the name, the Fowlkes meningioma, it's probably going to be on the Fowlkes cerebri. Interestingly enough, we do have a midline shift. It looks like here would be the midline, and our ventricles are slightly pushed over. Kind of unsure what is causing that. But so look along the midline and see if you see something coming in. Chances are it's very hard to distinguish, but here it is. Here is what is slightly hyperdense than the surrounding brain tissue. And so we see this nice rounded density here. So with the injection of contrast, if we load it up, we can see that it holds the contrast very well. And so this is a characteristic, once again, of meningioma. Okay, this is our third link, and probably our most detrimental link as well. If we'll look, this is a contrast enhanced scan. As we can see, the vessel's coming up, and we're scanning through, and we're told that this is an olfactory meningioma. And so as we're coming in, we start seeing something at the base of the skull, and we keep coming in, and we're seeing this huge mass. There's associated edema on the other side, contrasts very well, and probably the associated edema on both sides is simply a result of the mass getting very large and compression in the brain. We see this mirrored out with the compression of the lateral ventricles, the obliteration of probably the left lateral ventricle with compression of the right lateral ventricle, slight midline shift to the right. And that's pretty much it. Notice you can just see the borders very well with associated edema. But the big thing about meningiomas are they're going to hold the contrast very well. It'd be very interesting to see what this looks like without contrast, but we're not given that option. So this is what you're going to look for on a meningioma. Hopefully you're not going to see anything this large. Hopefully it's going to be along the lines of what you saw in the previous images, but this is what a meningioma can look like when it gets quite large. So let's return back to our slideshow now. Additionally, here's a meningioma that we're seeing on a coronal image. This is Fowlkes cerebri with a meningioma line right here. And so we see that this is with contrast because it's held it in. Notice this is one of the 20 to 25% of the cases that actually hold or that have calcifications. We see this slight increase in density here and here. And so this is calcifications that are inside the Fowlkes or inside the meningioma on the Fowlkes. Additionally, here's another meningioma. Notice it's on the midline as well. We have contrast enhancement coming in the arteries, and we have this area here, this mass. And typically, it almost looks the same as the one that I showed you that we scrolled through, the olfactory meningioma. However, it's not as large. So it's pretty much in the same location, but notice it's not causing as much of an abnormality. You don't see really any edema or swelling of the brain in this area. So that brings us to Cholesteatoma. We see that it's a destructive lesion of the skull base that erodes and destroys important structures within the temporal bone. It elevates the risk of the brain abscesses and possible meningitis. It consists of a squamous epithelium trapped within the skull base as it expands at the expense of the bone that surrounds it. Pressure causes bone remodeling, and enzymes within tumor causes increased osteoclastic activity. Once again, osteoclastic means breaking down. Osteoblastic means building up. So it causes the bone to be broke down without actually building it up. And this is a result of squamous epithelium simply being trapped. And so because it's trapped and the cells divide and expand, it causes bone remodeling. What we mean by bony remodeling is basically osteoclastic activity. Usually bony remodeling is a result of osteoclastic and osteoblastic remodeling or technique. But in this case, it's just the bone being broken down. So there's three possible causes for cholesteatoma. Number one is congenital, which is the squamous epithelium gets trapped within the temporal bone and then expands. Primary acquired is a tympanic membrane retraction, and secondary acquired is injury to the tympanic membrane. So the other two cases are abnormalities with the tympanic membrane, but the most probable cause is congenital abnormality. So the associated symptoms are painless autouria, a hearing loss, dizziness, drainage that is unresponsive to antibiotics. And so that's typically what you see is just abnormalities with the hearing, as that's where it's going to go in the temporal bone. And so because you can have abnormalities with the hearing, you can have also dizziness, which is basically mirroring inner ear infection, which causes fluid buildup and inability to actually have the balance that you once had, or the equilibrium. Also, you can have drainage that is unresponsive to antibiotics. Feel like your ears are draining consistently, and or not draining at all, and you're given antibiotics to hopefully clear this up, and it never works. So all of this can be a sign that kind of leads you to cholesteatoma. So to diagnose this, we have CT, MRI, and audiometry. And so basically, analyzation of the hearing structure of the ear. CT and MRI both have their benefits, but audiometry actually would prove quite beneficial as well. So in terms of CT, cholesteatoma should be added in those cases, or CT should be added in those cases where cholesteatoma is detected with MRI. CT is needed for preoperative planning, such as reconstruction of the ossicles if needed, and to exclude perforation of the bony tegment. So basically, usually cholesteatomas are found with MRI, and then CT is added as an afterthought to hopefully assist in surgical planning. So let's go to these links and see what a cholesteatoma actually looks like. Okay, on this one we're looking at a coronal image. So this is our right side, this is our left side. And notice we typically want to have symmetry in all of the structures so that we can compare very closely. So as we're coming in, we're seeing that this is on the right side what it should look like. The left side is slightly abnormal. And as we're going through, we start seeing this, what looks to be a mass on the inside of the EAM. And notice on the right side there is no mass. As we continue on, we see that in the bony structure of the skull, where the mastoid air cells are, we have almost obliteration. Here, the mastoids are not really clearly defined. and we have what looks to be a bridge between this area and this area where the mass actually is. And so it looks like it's causing bony remodeling, invading this area of the brain or area of the bone. And we see this actually mirrored out on this. We see that there's an opening here, whereas there should be none. So if we actually look at it in terms of kind of an oblique scan, we see that we have, or not an oblique, but more a coronal / oblique. We see that we have this area here. And notice how we have this opening that is basically a communication between two areas of the mass. And that's typically what a cholesteatoma will look like. And notice how very small it is. They can have very significant impacts in patients' life simply because of what it does and what it destroys. So here we have another cholesteatoma, and we can see it coming in here. We see it enlarging here with possible bony erosion there. And so here is possibly the most severe portion of it as well. And then possibly bony remodeling there. We switch views. We see that we have the cholesteatoma there, with possible invasion of the bone in this area. So basically, that's what we're looking for, these little small masses like this. So let's go back to our slideshow now. Okay, an acoustic neuroma. An acoustic neuroma is also known as a vestibular schwannoma, and we see that it is a benign, slow-growing tumor that develops on the main nerve leading from the inner ear to the brain. It occurs in 0.7 to 1.0 of people per 100,000, so it's quite uncommon in people, and this is something you may never see. It appears to result from a malfunctioning gene on chromosome 22, so keep this in mind. Appears to come from chromosome 22. This gene produces a protein that helps control the growth of Schwann cells covering the nerves. So it's an abnormality in the covering of the nerves, or the Schwann cells. Associated symptoms are, as we might guess, hearing loss, ringing in the affected ear, loss of balance, dizziness, facial numbness, and or weakness. So all of these things can be representative of an acoustic neuroma. Once again, a workup for diagnosis is quite similar to cholesteatoma, with audiometry, MRI, and CT all playing a key role in diagnosis. CT may show erosion and widening of the internal acoustic meatus. The density of these tumors on non-contrast scanning is variable, and often they are hard to see, especially on account of beam hardening and streak artifact from the adjacent petrous temporal bone. Contrast enhancement is present but can be underwhelming, especially in larger lesions with cystic components. So it's very hard to distinguish an acoustic neuroma on CT. So what we're looking for on this scan is very, very complex to actually find. We do have slight enhancement here versus nothing here, but really the key thing is this area. Notice how a very underwhelming contrast enhancement, but there is slight contrast enhancement. The reason it's very hard to distinguish is because we have all of the lines that are running here due to the increase in density in this portion of the skull. So it's very hard to really distinguish anything in this image. That's why MRI is utilized to a higher degree here. Here we have a slightly more enhanced image. We see that we have dense bones here, but we have this rounded density. It does have contrast enhancement. And notice where it's located. This is going to be typical for an acoustic neuroma. So that brings us to a pineal gland tumor. The pineal gland develops during the second month of gestation. Pineal tumors arise from cells located in and around the pineal gland. Pineal tumors make up 8% of all brain tumors in children. And the most common types of tumors are the germinomas and teratomas, which both occur predominantly in males younger than 25 years of age. Most result from displaced embryonic tissue, malignant transformation of the pineal parenchymal cells, and transformation of the surrounded astroglia. Symptoms include headache, nausea, vomiting, and pupillary inequality. So pupils dilate to unequal dimensions. So the workup for diagnosis is MRI and CT, with MRI probably playing a slightly larger role than CT in this effect. Germinomas appear as hyperdense and isodense masses that tend to deform or displace the posterior aspect of the third ventricle. So germinomas are going to have abnormalities in the third ventricle. Sometimes they have calcifications as well, and they enhance with contrast injection. So germinomas are going to be around the third ventricle, and they're going to enhance with contrast injection. Teratomas appear as hypodense masses and have internal calcifications and much less enhancement than with germinomas. So we're going to look for internal calcifications for teratomas. However, I could not find any images for those, and so typically your test will just kind of encompass just the lecture portion, not the images. So that brings us to a pituitary adenoma. The pituitary gland is the master gland of the body. It controls most of the body's endocrine functions. Pituitary adenomas are typically benign and are slow growing. They are relatively uncommon, which occur in 1 out of every 1,000 adults. Microadenomas are less than 1 centimeter in diameter, whereas macroadenomas are greater than 1 centimeter in diameter. So definitely know these, put a star beside of it. The difference between micro and macro adenomas. Pituitary adenomas arise from unknown origins, and we don't really know what causes pituitary adenomas. The symptoms of pituitary adenomas are a headache, vision loss, particularly loss of peripheral vision, nausea, vomiting, fatigue, weakness, cold intolerance, constipation, low blood pressure, body hair loss, sexual dysfunction, unintended weight loss or gain, and excessive growth. Typically, what we focus on pituitary adenomas are the excessive growth, which can result in gigantism and things like that. Pituitary adenomas are easily diagnosed on MRI, CT, not quite as much, but it can be utilized to demonstrate somewhat of the pituitary gland. But MRI is usually the modality of choice. We see that in terms of CT, you should see a focal region of hypodensity within the gland. And following contrast enhancement, the tumor will be isodense to the normal pituitary gland. So here we have an MRI scan, and we see the sella here, and this is where the pituitary gland should sit. And we have this area with what looks to be a hyperdense area on the inside of it. Here we can see that it has enhanced with contrast, indicating that there is possibly a mass there. Here's a pituitary adenoma in terms of CT. As we can see, due to going through the base of the skull, it becomes quite difficult to discern where we're actually at and what we're looking for. But probably this person has had an MRI, and we're doing a CT as well, just to kind of get a full picture of the patient. And so, as we can see, we have contrast enhancement on the midline. So that brings us to an arteriovenous malformation, or an AVM. That's what we're going to typically call them, is an AVM. So what you're going to hear it referred to from probably this point on is an AVM. It is an abnormal connection between arteries and veins, and it's typically a congenital abnormality. It can develop anywhere in the body, but most often occurs in the brain or in the spine, not the spin. Initially, it appears as a tangle of abnormal arteries and vessels, and about 1/4 of AVMs hemorrhage by age 15, and the majority become symptomatic by the age of 50. And so AVMs are not something that just exist in the body and never cause any problems, but over the course of time, as the body gets some wear and tear on it, it will become quite problematic. So there is no genetic, demographic, or environmental risk factors for cerebral AVMs that have been identified. So really, we don't know what the causation is. Typically, though, we feel that it is congenital abnormality, something that just occurs at birth, that we really don't know what is the triggering incident for. It's just how the body is actually made. Symptoms of an AVM are seizures, headaches, progressive weakness and or numbness, paralysis, vision loss, inability to understand others, and severe unsteadiness. So if you look at all of these symptoms, they almost mirror the effects of a stroke. And so it'd be very easy to be looking for a stroke only to find an AVM. So used to be the most common way to diagnose an AVM is cerebral arteriography. However, CT and MRI have done such an excellent job here recently of demonstrating AVMs that we typically use those, with cerebral arteriography coming later. So in terms of AVMs and CT, without contrast, you're going to see an isodense to slightly hyperdense mass, calcifications in 25 to 30% because we're dealing with vessels, and possibly atrophy. However, where AVMs actually really shine is with contrast, so that you can see a hyperdense, serpentine appearing vessel with contrast enhancement. So let's look at these images. Okay, on our initial scan, this is without contrast. You're going to see that it's very hard to distinguish anything being abnormal in this area. So if you were looking for an AVM, it'd be very hard to distinguish where it potentially could be. It looks like there's slightly an abnormality here, but we really don't know. So let's go down to CT angiography, and hopefully this will kind of allow us to distinguish where this abnormality is. And sure enough, we do see this area here. This is an AVM, and what an AVM really is just a tangle of blood vessels kind of mixing everything up. I kind of label it or compare it to making a rubber band ball, and to where basically it's all this collection of rubber bands and all just kind of tangled up differently. And that's what we see here, is that it's just kind of just a tangle of things, or a tangle of wire or something like that. And as you can see, you have individual vessels, but it's all just kind of wrapped inside this big ball. And so that is typically what your AVM looks like. And also it causes this abnormality here as a result of the tangle here. And so here we have the blue being the draining vessels. Okay, so let's go to an. So here's an MRI image, and it looks quite impressive as well. You can see the tangle of vessels, and notice how some of the vessels are extremely dilated, going in like this, due to the effect of having this tangle of vessels. Here is angiography. As you can see, this is a tangle. It should look like this. We have this huge mess. Notice we have dilation of the vessels as well. Here is CT angiography with volume rendering, and we see that we have this tangle of vessels here. This is typically what an AVM will look like on volume rendering. However, we don't often utilize volume rendering because you get something that looks like this. It's just kind of looks very messy, and you really can't really distinguish very much of anything on it. Here is an AVM in terms of CT as well. Notice we have individual blood vessels going throughout, but also we have a midline shift. So that brings us to a brain aneurysm. An aneurysm is a bulge or ballooning of a blood vessel, and in terms of brain aneurysms, it's in the brain. It can leak or rupture, causing a hemorrhagic stroke. Most often occurs in the space between the brain and the thin tissue covering the brain, resulting in a subarachnoid hemorrhage. Many brain aneurysms will not rupture. However, once they do, they immediately become a life-threatening condition. So we have possible causations as atherosclerosis or hardening of the arteries, and hypertension, which kind of goes along with atherosclerosis. And so due to the increased pressure that the heart has to pump at, it basically causes the blood vessels to become weak and rupture. The brain blood vessels are very weak in terms of the body as well, and so it's not uncommon, or it's quite common, for aneurysms to occur in the brain simply because of the weak nature of the vessels in comparison to other regions. Often, there's no symptoms of a brain aneurysm until rupture. Some possible signs are sudden extreme headaches, nausea and vomiting, blurred vision, seizure, and loss of consciousness. All these things can be a result of brain aneurysms, or possible symptoms of brain aneurysms, but oftentimes there are no symptoms. So the workup for diagnosis is cerebral arteriography, CT, and MRI. However, cerebral arteriography usually comes later, once the brain aneurysm is diagnosed. CT and MRI are your initial phases to really see what's going on inside the patient's head. So without contrast, many aneurysms are indistinguishable unless ruptured. If ruptured, non-contrast scans will demonstrate a subarachnoid hemorrhage, and they will appear as if you have injected contrast. So that's what you want to keep in mind, that on brain aneurysms, if one is ruptured, it's going to look like you've injected contrast into the patient, even though you haven't. And so this is something that I've actually experienced with some of my patients, this appearance of injecting contrast when you hadn't. We had a lady, and she was in her mid-50s, and she was complaining of severe headache, nausea, vomiting, just sudden onset, quite severe. So they bring her out to the ER, and we take her in the scanner. And as we have her on the scanner, she's getting sick, and so we're having difficulty making it through the scan. So we actually make it finally through, and me and the other tech actually just look at each other because it looks like we've injected contrast all through her brain, but we've not injected anything. And so we put her on the table, rush her back to the ER, tell the ER doctor that something crazy is going on, and we'll get the images right to him. We send it out for a reading, and the radiologist that was reading at that time believes there to be around 3 or 4 slow leaking aneurysms in her brain. And so they were giving her things in the ER before they shipped her out to bolster her blood. And so they ship her out, and they repair the aneurysms, and actually she's doing quite well today. But that's something that you're going to see, that if they're ruptured, it's going to look like you've injected contrast. Or with contrast, it can look like a berry hanging from a tree. And so we say that, and so it looks something like this, with just a kind of a ballooning out effect here. Generally, they're round in nature, and we'll see that as well. That's why they look like a berry. So let's look at brain aneurysms. Okay, so on this image, on our first link, we have a brain aneurysm, and it says with rupture. So let's see. So here we have some blood, and we have blood here. And notice it kind of almost looks like you're injecting with contrast. Notice we have blood out here, here, and a significant amount of blood in the lateral ventricle. And so that is almost mirroring what a stroke, a hemorrhagic stroke, looks like in appearance. Okay, so here is an aneurysm that has not ruptured yet. So as we're scanning through, notice we have this area here. And notice how round it is, and we can see that there is a vessel supplying it. There's calcifications inside of it, as we can see here. And so that is an aneurysm. Let's continue down and look and see what it looks like in terms of volume rendering. As we can see, looking down superior to inferior, we can see the vessel here, and it's large and it's ballooned out, which is consistent with the aneurysm. Here's a coronal view as we scan through the patient, and notice we can see it coming in, very well defined, clearly defined, and we can see the vessels actually coming out and supplying it. So that's pretty definite that this is an aneurysm. Here is just axial, and we can see the vessels coming in and supplying, and the vessels leaving as well. Here's a sagittal image. So as we can see, we have the vessels coming in, supplying it, and the vessels leaving. So in this image, we can see another aneurysm residing right here. We can see the aneurysm here, and that's even without any contrast being injected. Here is an arteriogram, and so we can see the aneurysm clearly defined. Notice how great of definition it actually gives us in terms of the aneurysm, but based on what you have to do to achieve this, CT and MR are much more effective in initial phase of diagnosing. Here's an aneurysm rupture once again. It looks like subarachnoid hemorrhage. We have blood going all the way through the circle of Willis, kind of filling in these spaces. Looks almost like we've injected with contrast. However, it's safe to presume that we had not injected with contrast here. So that brings us to our last topic, which is hydrocephalus. Hydrocephalus is a condition you'll probably see several times throughout your career. And in hydrocephalus, we see that cerebrospinal fluid normally flows through the ventricles and bathes the brain and the spinal column. However, Hydrocephalus is the buildup of cerebrospinal fluid in the ventricles deep within the brain. So it accumulates in the ventricles and doesn't have a way to drain. It increases the size of the ventricles and increases the pressure in the brain, which results in damage to the brain tissues, ultimately leading to impairment of brain function. More common in infants and older adults. So the role of cerebrospinal fluid is to keep the brain buoyant, allowing the relatively heavy brain to float within the skull. It cushions the brain to prevent injury. So if the brain did not have this cushioning effect, then any kind of physical movement of the body would virtually harm the brain. So this is what cerebrospinal fluid is in charge of doing. And it's also in charge of removing waste products from the brain's metabolism. So the brain actually is made up of a collection of cells, and because the cells have metabolism, the brain has waste products that have to be removed, and that's accomplished through cerebrospinal fluid. Also, its role is to flow back and forth between the brain cavity and spinal column to maintain a constant pressure within the brain. And it compensates for changes in blood pressure in the brain. So, as we know, our blood pressure is constantly fluctuating, and the cerebrospinal fluid is in charge of normalizing this for the brain. So, hydrocephalus, we find, results from an imbalance in the production and absorption of cerebrospinal fluid. And there's several things that can result from. Number one is obstruction, which reduces the flow from one ventricle to another or from the ventricles to other spaces, so that the cerebrospinal fluid can't get to where it needs to simply because it's obstructed. Another is poor absorption, so the blood vessels can't absorb the cerebrospinal fluid, and so it accumulates. And the last is overproduction, which means that the body overproduces cerebrospinal fluid. There's no problem with it flowing in between the ventricles, but there's just overproduction, which then causes an imbalance and then results in hydrocephalus. So the symptoms of hydrocephalus, number one, is an unusually large head for age, such as infants and small children. You have a head that is out of proportion due to the body size. Another is vomiting, sleeplessness, or sleepiness, seizures, blurred vision, headache, loss of coordination, loss of bladder control, and memory loss. So all of these things kind of go with abnormalities to the brain. And so as progression of hydrocephalus actually continues, we will see that these symptoms would increase in severity and become more acute. So the workup for diagnosis for hydrocephalus, number one is the simple neurological examination to see how well the patient is actually functioning and what kind of motor skills, and just to see if there's any deficits there. Another is ultrasound, which is kind of up in the air in terms of whether it's effective or not, because based on the amount of things that you're having to penetrate to see hydrocephalus, it might be very difficult to actually get good images for ultrasound. That's where MRI and CT actually come in. In both of these modalities, it's very easy to acquire excellent images and to really see what is going on here in terms of hydrocephalus. So hydrocephalus really doesn't have to have any contrast, because what we're looking for is enlargement of the ventricles. So what you should see is enlargement of the ventricles well beyond the patient's age. As we all know, as you age, your ventricles are going to become wider, and so one of the things that you can look for in comparison to old and young patients is widening of the ventricles, primarily the lateral ventricles. However, if you have wide ventricles in a patient who is very young, then this typically indicates hydrocephalus, because there is too much accumulation of fluid in these ventricles. So let's look at some images online, see what they actually look like. So here we have an image. Let's see if we have a patient age. Really not told how old this patient is, so let's look at it. Okay, so here are your lateral ventricles, septum, callucidum, and somewhere around here is supposed to be your third ventricle, but look at how large this is. I'm guessing this is your third ventricle, basilar cistern, and look at how large the lateral ventricles are. And the thing that always fascinates me about hydrocephalus is, in cases like this where the disease has progressed to this extent, is what type of patient was this that came into the radiology suite. how much functionality do they actually have? Were they able to function on their own, or were they incapable and relied on others to help them live their lives? Because it would seem here that due to the amount of brain matter that is actually just being absorbed and pushed out based on the size of these ventricles, how does this person normally function? And it would be very interesting to see, because you're looking at all of your motor areas, all your vocal areas, all of these things that make your body function being just completely obliterated. And if you look at this is almost comparing hydrocephalus to an ischemic stroke. And we see that when patients have an ischemic stroke and it wipes out a large majority of the brain, they aren't able to function very well. So it'd be very interesting to see how well this patient actually is able to function. And so, as we see down here at the bottom, it says non-obstructive hydrocephalus, meaning that it's just simply due to an overproduction of CSF, probably. So let's look at another image. Okay, here's another image of hydrocephalus. And as we can see, the lateral ventricles are quite wide, but we still do have a lot of brain matter in between. So this patient does obviously have hydrocephalus, and let's see if we've got any facts about it. We see that this patient's age is 55, and he's a male, and he's Caucasian. And we see that the reason for the scan is congenital aqueductal stenosis. So the patient is born with the aqueduct being severely compromised, so that there isn't communication to allow this to drain, probably into the fourth ventricle. And so we're seeing widening of the lateral ventricles here as well, with also widening of the third ventricle here. But we would also expect the patient, based on 55 years of age, to have slightly abnormal ventricles anyway, to be slightly enlarged. And so the difference between the enlargement and the hydrocephalus can be questionable, but we do see that there are a lot of widening portions here. So that is typical hydrocephalus. Lateral ventricles. We have this thing that divides it in between septum pellucidum. And so we have the lateral ventricles coming in. We do have slightly enlarged lateral ventricles, but not to the extent that we previously saw. Here's another image with a very large lateral ventricles. As we can see, we have the septum pellucidum dividing here, but the lateral ventricles are quite large, and so it'd be very interesting to see what kind, how well this patient functions as well. And so that is it for part one of the central nervous system. If you have any questions, just feel free to give me an email. If not, then we'll continue on into part two next week. The central nervous system, part two. Okay, so we'll pick up with an epidural hematoma, which, as the name implies, this is going to be in the epidural space. This is associated with a mass of blood and is frequently formed as a result of trauma to the head. So that's going to be one of the key deciding factors, is you're going to see trauma to the head. It's usually located between the skull and the dura mater in the temporoparietal region. And so basically, in the juncture between the temporal bone and the parietal bone, that's going to be where it's actually at. And judging by the name, the epidural, we see that it is above the dura mater. And if we'll recall the layers or the meninges, the dura mater is the layer that is closest to the cranium, so there's It's blood that basically pools in between the cranium and the dura mater, and that's why we call it an epidural. Or epi means above, and so above the dura mater. It's strongly associated with a linear skull fracture, and this really causes a tear of the middle meningeal artery. And so because you have a tear in this artery, that's where the blood is actually going to come from. It causes a tear of the middle meningeal artery, which causes the hemorrhage between the skull and the meninges. And so you build up this blood supply, and as the heart continuously pumps, this epidural hematoma grows larger and larger. And it can be associated with a loss of consciousness, hemorrhage, headaches, dilated pupils, increased intracranial pressure, nausea, vomiting, dizziness, and convulsions. The increased intracranial pressure is pretty much self-explanatory because you have the cranium being here, and the dura mater should be up next to the cranium. But if you've got blood that is pulling into this area, then you may have this space here, and so that's going to thereby increase the pressure on the brain and cause many different things like consciousness changes, difficulties and doing many things, or having severe headaches, things like this. But one thing to keep in mind is that usually with an epidural hematoma, you're going to show signs of trauma, and so it's not going to be that far-fetched to see whether you have one or not. And so the workup for diagnosis, really there's no labs or anything. It's just simply CT or MRI. And in terms of CT, we're going to look for an underlying fracture. An acute state hemorrhage will appear hyperdense. So if it's just come on all of a sudden, it's going to appear hyperdense, or it's going to appear white. A subacute stage of hemorrhage will appear isodense, and so it's going to appear same as brain. And then a chronic stage, which several months or years, is going to appear as black. And so just simply by judging what it looks like will kind of give us an indication of what stage we're in. We have blood in this area, and then we also have the epidural hematoma here. I notice that it's on the side of the head in the temporoparietal area. I notice we do have a shift. See how we have bowing going inward? This inward pressure is basically caused by this epidural hematoma. So we can reasonably suggest this patient did have blunt force trauma. Here's an MRI, and you can see this large distended area here. Notice that we're slightly up on the parietal area, so this is going to be parietal, and we really don't see any thickening of the scalp here to really suggest that maybe this is where the trauma actually happened. Here is one with a linear skull fracture. Notice here and here. Patient has severe swelling starting at the frontal bone and going all the way around. So quite severe skull fracture there, and as we can see, we have the hematoma here. It's questionable as to whether this is going on acute or subacute based on the level of hyperdensity that we're seeing. We're not seeing it being as bright white as the skull, but we do see still some hyperdense areas. Notice that there is a shift here as well, corresponding to the increased intracranial pressure. Here we see the skull fracture actually being much more problematic than this area. So just as we saw with an epidural hematoma, a subdural hematoma means below the dura. And so if we notice or remember, it's dura, arachnoid, and then pia mater. And so subdural means below the dura. And so this is usually associated between the dura and the arachnoid. And this is a collection of venous blood located between the dura mater and the arachnoid membrane. It usually develops as a result of the head hitting an immovable object, seldom associated with skull fractures. And so this is what happens when your head meets an object that does not move. And so quite common as well. Usually the result of the head striking an immovable object, such as a high-speed acceleration, deceleration. Related injuries could result in the tearing of the veins between the cerebral cortex and the dural veins. So something even as simple as slipping and falling and your head hitting the ground, that could result in a subdural hematoma. A car accident could result in this, but usually the thing to keep in mind is no skull fractures. That's usually the case here. Associated symptoms of subdural hematomas are headaches, changes in mental status, motor and sensory deficits. Pretty much all of these things, such as motor and sensory deficits, changes in mental status, and even headaches, simply because of what is going on inside the head. So it's not uncommon to see everything caused just simply by increased intracranial pressure. So the workup for diagnosis is quite simple, CT or MRI once again. Really no laboratory results needed for this. Once again, acute stage appears as hyperdense or white. Subacute stage appears as isodense or probably a little gray. Hypodense appears as black. And so the transition, we're going to have all three important contrast features of this. We're going to go from white to gray to black. And so when it's chronic or it's been there for quite a while, it's going to appear black. This is a very acute stage. Notice we have a lot of pooling of the blood, and it's questionable as to whether this is something here too. But the one thing I want you to notice is this is straight sinus, and this is going to be the confluence of sinuses probably. But notice how we have the ventricles pushed over towards the patient's left. And so we have compression of the right lateral ventricle, as well as associated shift of the occipital horn of the lateral ventricle. And because of this intracranial pressure, many times the patient will be treated by cutting out a portion of the skull, maybe here to here, and removing it, and then allowing the pressure to escape, and then once the pressure is down, reattaching the patient's skull. So very, very dangerous points here with such a midline shift. Here we have another patient, quite similar though. We have this area which is blood, and we have a midline shift here with associated swelling of the brain increasing intracranial pressure here as well. So that brings us to brain mets. As we all know, mets means metastasis, which is the spread of cancer. And so metastatic spread of cancer from a distant site or organ to the brain is what we're going to be dealing with. And the most common primary sites are the lungs, the breast, GI tract, kidneys, and melanoma. Possible results of brain mets are seizures and maybe even loss of sensory motor function, headaches, loss of vision, things like that can all be symptoms of brain metastasis. And really the only way to look for this is CT, MRI, and I would like to add another one here, PET, because PET can play a pivotal role in determining if there are hot spots or lesions anywhere else in the body when you're going for your initial screening of cancer. So the manifestation here shows multiple discrete lesions with variable density along the gray-white matter interface. And you show a marked peripheral edema surrounding larger lesions. That's going to be something to keep in mind, this marked peripheral edema. And post-contrast shows enhancement of the lesions. So you should see these areas enhance due to the increased vascularity. So here is an image that I found of colon cancer metastasis. You have a lesion here, 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 here. I think those are all our lesions. Notice that we have an associated edema effect here. It's going to show up as a hypodense area, and notice how it's got a kind of a black appearance. That's what we're looking for in terms of edema. This is another example. We have associated edema. We have the lesion here, which is fairly large. We notice we do see signs of contrast enhancement on the inside, and it's variable in terms of the amount of contrast that it holds, but we also have this hypodense area surrounding it. And so that's the edema from this mass growing larger and larger. Interestingly enough, we have this area here, which could correspond to some associated edema. The patient does have a midline shift. Here is the midline, and notice we're slightly off. We have possible compression of the right lateral ventricle. The bottom portion of the ventricle seems to remain intact, but the upper portion of the lateral ventricle seems to have shifted. But this is the only lesion that we see in this patient's head from this image. So we're going to transition from the brain to spine. And so basically, many people forget that the spine is basically a large portion of the central nervous system as well, because the spine helps to protect the spinal canal or the spinal column and spinal cord. And so because of that, it's essential that we cover things that can disrupt the spinal cord and cause things such as paralysis, loss of motor function. So the first thing that we're going to look at is spondylolisthesis. And basically what this is the displacement or slippage of a vertebrae over an inferior vertebrae. So basically, to simplify this, we're going to say that this is vertebral body here. We'll say that this is L3. And so what we're talking about with spondylolisthesis is that you have slippage to where it's went basically anterior, or it has went posterior. You could say that maybe L2 is normal and L3 has slipped backwards. And either way, what happens to the spinal cord in this instance when you have notice this. So basically, you have the spinal cord having to kind of do this number, kind of bending, and because of this, it can increase pressure on the spinal cord and cause severe pain, severe motor function deficits, and sometimes it can even cause paralysis if the slippage is great enough. And so, one thing that we have to memorize about this is that it can be either anterior or posterior in displacement. It does not have to be one or the other. It usually involves L5 over S1 or L4 over L5. And the reason for this is because these are the primary weight-bearing portions of the spine, and because of that, these areas just tend to accumulate a lot of injuries over the course of time. There are 4 types of spondylolisthesis. Type 1 is going to involve 25% of the vertebral displacement over the inferior vertebrae. So type 1 is 25% slippage. Type 2 is 50% slippage. Type 3 is 75% slippage. And type 4 is over 75%. So if you look at this, we have this much of slippage, which is probably equal to about 25%. If we were to have over 75%, you're looking at an instance where something like this. And so there's going to be severe impairment of the spinal cord. It may result from trauma, which seems to be an obvious case, acquired fibrous defects in the pars interarticularis, degenerative changes such as the disc and the facet joints, and congenital spine defects. All of these can cause spondylolisthesis. Symptoms of it are low back pain, stiffness in the lower back, perhaps loss of functionality, and poor posture due to tight hamstrings and knees bent. So basically, because you're going to be in so much pain and it's going to be so hard to do anything in your knees, you're going to feel like your muscles are tightening up, and it's more comfortable to keep your knees bent simply because of that. Plain film radiographs typically will do a fair job of demonstrating the spondylolisthesis. However, CT and MRI will yield a better result in looking at the spinal cord, with MRI being the true go-to area for this so that you can see any damage to the spinal cord. It's important to note that sagittal reformation is very essential. This is going to demonstrate a shifting of a vertebrae over an inferior vertebrae, and it's going to best demonstrate it. Coronal images really are not going to be able to show you this, as well as axial images. You're going to rely heavily on the sagittal images. Also, you're going to look for pars interarticularis defects. However, the big thing to remember is sagittal images. So here we have just a diagram of what spondylolisthesis actually is. We have what looks to be normal alignment here. If we draw a line through, we see pretty much normal alignment, and then we get this indentation here. It's questionable as to whether the anterior or the superior vertebrae have actually shifted anterior, or L5 has actually went posterior. I would favor that L5 has actually went posterior, but we don't really know. The only thing that we can actually discern is that we have from this point to this point a shift, and so that's probably around 25%. It's no more than 30%. So this could be a type 1 or a type 2. Here's a pretty severe, probably greater than 50%. So this is probably a type 3 at least. And notice we have the vertebrae here, and it should be sitting on S1 here. It's probably at least 65 to 75. It could even be more than 75%. The thing to notice is that we have the spinal cord residing in this area here. And the spinal cord has to make this abrupt shift to go down. And you can imagine the type of tension and pressure that this puts on the spinal cord. And so, very, very difficult here to really see that this patient doesn't have severe neurological deficits. Also, if we look at this, we say that this spinous process corresponds to T12. So this is L1, L2, L3, L4, L5. Okay, so this is L1, this is L2, this is L3, this is L4, and way back here is L5 on the spinous process. There seems to be some disassociation between the vertebral body and the spinous process. If I erase everything here, let's look at this slightly more. We see that we have a compression fracture here as well. Notice that there is a wedge-shaped pattern with the anterior portion of the vertebral body being greater than the posterior portion, and it looks like we have some fragmentation here. Based on this, we can say that there has been severe trauma to this area, and it would almost be questionable as to whether this patient does not have paralysis as a result of this trauma. This does not look like a birth defect, but this looks like all-out trauma. Here's a minor spondylolisthesis. We see some slight anterior slippage, probably around 5 to 15%, but we do see that it does create some impairment of the spinal cord, and because of this, we have surgical remediation which will correct this and hold them in place. And we see we have normal alignment. If we look at the posterior section and the anterior, it lines up very well. Here is the anterior. Notice we have an indentation. Posterior, we have to go outward as well. And so we do see that there is an abnormality here. That brings us to a burst fracture. A burst fracture is a vertically oriented fracture of the vertebral body with lateral dispersion of the fracture fragments. It's usually associated with fractures in the posterior elements of the vertebrae. It's usually a result of flexion or axial loading traumatic force. And so many people question what axial loading is, but basically it's coming down on the spine, landing like in a seated position, or a position to where it basically compresses the spine, and all of this pressure that you have just yielded has to go out somewhere. And so it basically targets the weakest vertebrae, and it kind of blows it up. I guess that's the best way of looking at it, and it'll become more self-evident when we actually look at the images. Typically, burst fracture is going to have low back pain and possibly extending down into buttocks, numbness, leg weakness, and possibly even paralysis. CT and MRI are going to be your best options. Plain film radiography can play a role in this, but to evaluate the spinal cord, you're going to need something greater than conventional radiography. You're going to look for fractures of the vertebral body, fractures of the pedicles and lamina, possibly showing a displaced fracture fragments in the spinal canal. That's always dangerous because these things can be like sand or
if you had sand in your shoe and you just continued walking barefooted, you didn't have socks on, and you were just wearing your shoes, you had sand in them. Over the course of time, this sand would basically wear your feet raw, simply because of the irritant and the friction going on there. Much is the same here. This can be very damaging to the spinal cord, simply because over the course of time it can basically wear through the thecal sac and cause nerve impingement. Here's a burst fracture. Notice we have 5, 4, 3, 2, 1, 12. So this is T11. And notice how we have basically the vertebral body just crumbled. We have a vertical fracture as well as anterior fragmentation. We have nothing going into the spinal canal as well, but we do have some maybe anterior displacement. Additionally, we go up to 10, 9, 8, 7 has a fracture, and 6 has a fracture as well. And the reason we can discern this is because looking at the inferior surface, notice how there is an area that is raised on it, and we have a wedge-shaped pattern here for T6. And so because of that, we can kind of feel safe in assuming that there's other fractures as well. But most severe is this one. Here's another burst fracture, and notice this one is much more severe than what we've previously seen. We have an anterior fragmentation with a vertical fracture going up this way. Notice how close we are to the aorta, and notice that we have posterior fragmentation back. If we trace the posterior portion of the vertebral body, we see that we have this great indentation. The spinal cord is only going through this small area. This impingement could be very much paralysis causing. Just simply because of this, this patient probably did not walk, or did not just have low back pain, but this patient probably had no ability to maybe even feel their legs, simply because of this traumatic event. Here's what an axial scan of a burst fracture looks like. Notice we have all kinds of fragmentation. We have fragmentation inside going into the spinal cord. We have all of these fractures, and it just looks like, what burst fractures always remind me of is if you were to take a drop of water out of a cup and then hold it on your finger and drop it back into the container of water, it'll create this ripple effect. And that's kind of what burst fractures actually remind me of, is when that water droplet hits, it causes all of this ripples, and the fractures are kind of like your ripples. I'd also like to mention that burst fractures typically are found in a lot of patients, well, a lot of cadavers, I guess would be the more appropriate term, that have jumped from buildings or jumped from high up places. These are found in a lot of those because of coming down at a certain point, depending on how you fall. It will cause axial loading of the vertebral column, and you'll see some burst fractures there. So that's typically something that you associate burst fractures with as well. So that brings us to a compression fracture. These are not uncommon at all. Compression fractures are fracture of the vertebral body that results in compression of the vertebral body. It occurs as a result of a combination of flexion and axial loading to compress the vertebrae. It can result from trauma, metastatic disease to the spine, and osteoporosis. You're going to see this in a lot of elderly patients that have osteoporosis. So it's not going to be very uncommon here to see any of this. Trauma, such as an MVA, will result in a compression fracture too sometimes, depending on how the patient was actually struck by the vehicle. And then if you have weakness in the spine caused by metastatic disease, it can cause compression as well. Compression fractures are going to be identified by having severe back pain and possible neurological deficits. These neurological deficits are not going to be as acute probably as those with burst fractures, simply because of the fragmentation effect, but compression fractures can yield very painful points in a patient's life as well. Once again, conventional radiography can be utilized to initially see what's going on, but to better demonstrate compression fractures, you need scans from multiple angles, which CT and MRI will do. So what you're going to look for once again is fracture of the vertebral body, possible fracture of the pedicles and lamina, and displaced fracture fragments that may compromise the spinal canal. So here we have a patient who has had kyphoplasty, which is the cement structure that is seen here. As we can tell, the patient does have osteoporosis simply due to the fact that none of the margins of the vertebral body do have any density left whatsoever, and simply because we have 3 levels that have kyphoplasty. We have severe compression fracture of this area here, with corresponding small compression fractures of the areas above and below. Additionally, looking at the posterior elements of the vertebrae, we see that we have an inward depression on the most severe compression fracture, compressing the spinal canal, causing it to have a reduced area going through here. Here is a compression fracture, very difficult to distinguish between it and a burst fracture, or at least on this one. We have anterior fragmentation and some posterior fragmentation as well. We have a line running like this and this. And so if one thing to kind of distinguish a compression fracture versus a burst fracture is that usually the vertebrae look compressed, kind of shrunken in size, and also the fact that we have horizontal fractures, whereas on the burst fracture we saw just simply vertical fractures. But we do see that the spinal canal does have some impingement here due to this posterior bone. So that brings us to a C1 fracture. There are 3 types of C1 fractures. There's the posterior arch fracture that occurs at the junction of the posterior arch and the lateral mass. A lateral mass fracture, which occurs unilaterally with the fracture line passing either through the articular surface or anterior or posterior to the lateral mass on one side. Then we have a burst fracture, which is called a Jefferson's fracture, and it's characterized by 4 fractures, all within the same area. C1 fractures can be either stable or non-stable. Many times, regardless of what we feel, we rule them out as non-stable simply because any kind of damage here will be life-threatening. So C1 fractures typically occur as a result of axial loading to the top of the head, and so basically coming down on something and compressing your head. Typically from swimming and diving accidents, which makes sense. You hit your head and your body just follows suit, and it loads up the pressure. Magnitude of axial loading will determine how severe the fracture is. So if you build up a lot of force, then obviously the fracture is going to be greater to a certain degree. So the possible symptoms of a C1 fracture are pain and severe neurological deficits. The neurological deficits are going to be pretty obvious, and typically the patient may not even be able to walk. If the patient knows that they have a fracture, then the patient won't be walking, the patient won't be allowed to walk, simply because of doing anything that might cause this joint to be even more unstable. So usually for a C1 fracture, conventional radiography is not sufficient, so that means that CT and MRI are your most efficient methods of diagnosing this. Here we have a C1 fracture. We have fracture at the anterior arch and at the posterior arch. This would almost be a Jefferson fracture, but we don't see a corresponding fracture here. Okay. Additionally, we have another C1 fracture. We have these areas here. Notice how the fracture is going to appear as hypodense in comparison to the bone that's surrounding it. Going to appear pretty much isodense as this muscle here. And so that's what we see. You're going to look for a line running anywhere inside of the vertebrae. So we have two fractures here. Here we have an anterior arch fracture, and it also looks like there's some degree of displacement. Notice how, in comparison, we are closer to the right side than we are the left. So that brings us to a C2 fracture. There are three types. Type 1 is very rare, which is simply just an avulsion of the tip of the odontoid. Type 2 is the most common, which is a fracture through the base of the odontoid. And fracture 3 extends through the upper body of the C2 vertebrae. So basically, if we say that this is the odontoid, type 1 is just going to be an avulsion fracture of this. Type 2 is going to be a fracture here, and type 3 is going to extend all the way down here. The result of extreme flexion of the head. So the head is bent backwards to a greater degree than what it should be. It's going to be associated with pain and severe neurological deficits. And once again, CT and MRI are going to be your best options. Plain film radiography might actually be able to demonstrate this to a certain degree, but not to the degree that would be acceptable for this. So here we have basically a type 2 fracture with possibly a type 3, because we do have a line running down. But we see that we have the odontoid just kind of laid over to the side. And if we notice, it looks like the head has been flexed over to the right in this coronal image. And so that's caused this. Notice we have narrowing here and widening here. So it's a very severe fracture. It's questionable as to if this patient actually survived based on what it looks like. Here's an odontoid fracture. This is type 2 or type 3, depending on what we're looking at. Based on this image, I believe it's a type 3 because it's going through some portion of the body. We see that we have fracture here and kind of going down. This coronal image kind of displays it even better. We see this fracture here and narrowing there versus widening there. Notice that we don't have really any abnormality with the spinal cord, though. So this patient would definitely be taken for surgery, but the prognosis is not as dire as some of the previous images possibly. So that brings us to a spinal adenoma. This is the most common tumor of the spinal cord. It's a benign, slow-growing, and it arises from the epidermal cells lining the central canal. It's really unknown what triggers their growth, only that they do grow. Pain is going to be associated with this, as well as leg weakness, and interestingly enough, a sphincter muscle dysfunction, which is typically a symptom of severe problems with the spinal cord. Bowel incontinence, that's something that is to be expected regarding this. The best option here is an MRI. CT just doesn't quite do this justice. So here you can see the spinal canal, and here we have this area, this rounded density inside the spinal canal. We can see it in all of these various planes and images. We have it right there, and so it's really impinging on the spinal cord as it's going down. So very important that this be remedied. That brings us to a spinal meningioma. They're benign, and they account for approximately 25% of all intradural tumors. They're characteristically hard, slow-growing, and usually highly vascular. They're believed to originate from the arachnoid cells located near the dorsal nerve root ganglia, and they result in pain, weakness, bowel and bladder dysfunction, and paresthesis. CT or MRI will be efficient in demonstrating this and diagnosing. In terms of CT, spinal meningiomas show a calcification within the spinal cord. CT myelography may demonstrate a blockage by an intradural mass. So here we have myelography, and here we have the mass.